The next topic is dialysis or delay. Preventing the final countdown with timely interventions. This is case study and the speaker will be Dr. Beena Unnikrishnan, Professor of Medicine and Head of the Department of Nephrology at Sri Mookambika Institute of Medical Sciences, Trivandrum. She is also an honorary senior consultant to SP Medifort. Over to Dr. Beena, please.
Thank you, sir. Good morning. We had so many talks. It has been very interesting. We went back to sulfonylureas and metformin. So I would like to continue as part of the previous lectures and talks. So we have so much of armamentarium with us. So many new drugs have come. Yet the complications are still on the rise. What you must understand is the most common cause, or more than 30 to 40% of the cause for renal failure is still diabetes, and it is increasing. So can we prevent that? So my objective is understand the condition, optimize the management of diabetic patients with CKD, and delay the progression of chronic kidney disease. So we take up a case. A 62-year-old man with diabetes, hypertension and dyslipidemia. He's on medications, metformin, telmisartan, hydrochlorothiazide, and his assessment shows that the BMI is 32, blood pressure of 140, 130, 150 by 80, and the eGFR of 32 ml meter square, and the albumin creatinine ratio is 242. And the serum albumin is normal, potassium on the higher side 5.1, bicarb of 20, and an HbA1c of 8.6, and LDL more than 120. So what we must understand on a practical basis, any patient who comes with diabetes, we have to screen, especially type 2 diabetes, we have to screen for kidney disease. How? By just doing a simple test of urine examination and assessing the creatinine and calculating the eGFR. And so how frequently? If it's the renal function is normal, you need to do it maybe just once a year. But if the staging is even more, there's high grade, you have to monitor the patient more frequently. So what is chronic kidney disease? Chronic kidney disease is a condition where there is some abnormality, some impairment. It may be a reduced renal function measured by eGFR, or some damage has occurred, and a simple test is by assessing the urine albumin. The other tests are like hematuria, any ultrasound scan evidence, all those, if persistent for more than 3 months, you can label this person as a chronic kidney disease. And what does KDIGO guideline help us do? It is classified CKD as the CGA system. You can do understand what is the cause. You must remember the eGFR and the albumin. Initially we were all eGFR centric, now we are concentrating more on the albuminuria, the grade of albuminuria also. Because we can understand what is the prognosis, what is the risk for my patient developing chronic kidney disease. And the stages are 1 to 5. So we not only detect kidney disease, we have to evaluate, is there some reason for the acute worsening? Are we safe in labeling that the patient is having chronic kidney disease? Can we find out any irreversible factors that can improve his kidney function? And with this, once a kidney function is stable, that is the creatinine remains stable, you can also do risk prediction, because we do not want our patients to land into dialysis or renal transplant. Do not give a negative thought to the patient that your kidney is gone and you're going to develop, go into a dialysis and all that. Even if the creatinine is 3 or 4, if you take care of that patient properly, you can delay the progression of the kidney disease. So what is the importance? Why manage chronic kidney disease? So is it just preventing CKD progression? No. What you must understand, most of our patients die. The cause of death is cardiovascular death. So if it's a diabetic patient, you know already there is a high risk for cardiovascular mortality. If there is chronic kidney disease, that increases threefold. So that is our aim. It is not just managing the kidney disease, but also preventing cardiovascular events. So my patient has now, I can put him as diabetic kidney disease with a grade, his stage is now grade 3B and A2. So where does he come? He comes into the stage of, you see this is a heat map created by the KDIGO guidelines that helps us to prognosticate and helps us to give better care for our patient. So why? Because grade 1 to grade 2, actually there is high risk for cardiovascular death. Once this becomes grade 3, there is more chance for other complications associated with kidney disease like your mineral bone disease, acidosis, and electrolyte impairment. Once it becomes stage 4, you know the person is going to worsen, but do not be disheartened. Don't give negative, always motivate your patient. Don't say this is the end. You can still continue if the patient continues with his medications properly and a good lifestyle. So do not, so you can stratify your patient. What is your aim? Initial period, the grade 1, grade 2, it can be managed by a physician. Of course, by grade 3, you need to have a specialist care. So targets, so many targets, we have so much to achieve. And how we try to achieve the target, you must remember, it should be a goal, not just looking at the glucose. The patient should be the center, the patient should be able to take care of the situation. And we must all address each and every organ. So, it is a comprehensive treatment. So, comprehensive treatment where you can prevent and treat clinical complications, symptoms and signs, blood pressure, maximize your health. As I said, improve the quality of life by making the patient do exercise. So it's very important that they do not be disheartened. So appropriate management. And in this process, we are also looking at the CKD outcome. We must minimize the risk of progression and manage other complications along the way. So for any patient, I tell my patient, this is the most important, not medicine, it's a lifestyle management. Your health is the most, health can be controlled by your proper diet and physical activity, avoiding tobacco products and weight management. I think more than 40% of the function, as Sir said, however we can prevent the complications is by bringing down the glucose level. So this is an easy method and a cheap method as well. So first, important, remember, it is a lifestyle management. And next comes the drugs. The first line drug therapy is, as we know metformin is there. But for my patient now, his GFR is around, eGFR is around 32. Now, is he going to progress? Should I stop metformin? What should I do? Yes, the thing is, for metformin, we do not start if it is less than 60 ml, but we do continue with the medications. And when it becomes less than 45, we reduce the dose to half. And by 30, we stop it. Of course, now we have the new drugs, SGLT2 inhibitor, and that is what everyone is so excited about, that if you can start it, even if the eGFR is more than 20, and also in those with heart failure, irrespective of the level of albuminuria. So continue this, you can continue even if the patient has worsening of the renal parameters, but remember, you have to withhold this drug in times of fasting, surgery, or critical illness. We must also remember that once you start this medicine, there is going to be a dip. There is definitely going to be a dip in the GFR, but that is not going to remain like that for long. And by 3 to 9 months, it is going to catch up, and the SGLT2 will do a better job. So next is we have the other ones, GLP-1 inhibitors. Of course, this is found to be especially useful in those who are obese and those who have cardiovascular disease. We target a blood pressure of less than 120, but be sure how you're controlling the BP, frail patient, limited life expectancy, don't be too aggressive. And then RAS inhibitor is an important armamentarium, and avoid any combination of this, but definitely it has been found to reduce our risk for worsening of kidney function. And we have, in the process, look out for hyperkalemia, look out for eGFR, reduction in eGFR. Here also we expected more than 30% reduction in the eGFR. So we also remember monitoring the hyperkalemia. Do not be alarmed. Of course, more than 6.5, you have to treat the patient. But in this process, identify what can be the cause for hyperkalemia. Is it drugs like NSAIDs, or is it due to the diet that the patient is taking? So as we go on, additional risk-based therapy is we use the non-steroidal mineralocorticoid receptor antagonist. In this also you can use it. The GFR is more than 25. ml per minute, but in the process, look out for hyperkalemia. We should address the other complications like cardiovascular disease, anemia, the mood disease, and acidosis. And remember drug safety. Which drugs are you prescribed? Is it in the renal dose? And in the process, make sure the patient knows the sick days when you have to stop these medicines. Certain medicines has to be stopped, otherwise that can cause acute worsening of the kidney function. So our patient, what can we do? I would look at this patient and find out any other cause for acute worsening, advise a proper diet and his lifestyle, improve his lifestyle. I will try to improve his HbA1c, but it may not be reliable when the renal parameters are worsening because it's associated anemia. Metformin I shall stop if the GFR is becoming less than 30. I will consider empagliflozin, semaglutide, finerenone, depending on the pocket of the patient, and maybe change to the rosuvastatin to atorvastatin. So I would like to say the takeaway for everyone is that we monitor. It's very important that we monitor the renal parameters depending on the stage of the patient's, the CKD stage. Monitor the potassium level, and do not be alarmed if there is worsening of the renal parameters. If there is up to less than 30% of GFR reduction is expected. But when they say serum creatinine, you must remember 1 milligram, it goes to 1.3 milligram. When your patient comes your next visit, you will not think, oh, 1 minute, this may be just a lab error, isn't it? But when you convert it to 88 micromoles, it's a different thing. It becomes more than 240. But when this sort of report comes, we are never bothered if 1 milligram becomes 1.3. So I would say in our setup, and especially if you think your patient is reliable, is going to come a regular follow-up with you, yes, start all these medicines with confidence. And optimize the blood pressure is also very important, not just requiring the BP to go down. We now need our patient to be walking about and play an important role in the society. Yes, SGLT2 inhibitor is a very important drug. It has so many pleiotropic effects, and we are looking forward to it. Maybe in the long term, the cost, it may be, will not be a factor because you are preventing other complications. So for risk reduction of kidney disease, everyone should go by the urine albumin creatinine ratio and try to treat, and definitely there will be a response in those, especially if it is more than 300 milligram per gram. So remember, our patients, we should have a comprehensive management and it should be a personalized treatment. Each and every patient may be different, so it is our role to play, help them out in preventing them from getting worsening of the chronic kidney disease. That is progression of kidney disease, and prevent other complications due to diabetes. Thank you.
Thank you very much, Dr. Beena, for telling us about the various tools available for delaying dialysis in diabetic kidney disease. Actually, about 40 years back, when I passed my DM, Kidney International came with an article, "Is diabetic nephropathy preventable? A $1 billion question." See, over the 40 years, we have discovered so many tools to delay dialysis in diabetic kidney disease. 40 years back, diabetic kidney disease was passport to the other world. I suffered because even my father had diabetic kidney disease, and whether to dialyze or not to dialyze, I had to approach many specialists. And at the end, I put him on dialysis and he hardly survived 6 months. But now, our patients are surviving longer on dialysis, and we have kidney transplant, which is giving them excellent quality of life. So with these remarks...
But at what expense is what you must realize, it's an expensive treatment, and which is essentially preventable. That is what you should, that should be the message.
So with these remarks, both the topics are open for discussion. We have 5 minutes, and there are any questions, Dr. Radhika and Dr. Beena will be very happy to answer them. Over to questions, please.
Dr. Radhika, the topic is bladder dysfunction in diabetes. In what way medical management differs? In what way medical management differ in bladder dysfunction in diabetes with the prostate? because some drugs causes you are giving for frequency or incontinence. That would precipitate retention, especially the imiprane, nortriptyline and all sometimes. In what way, when the patient has got the prostatic hypertrophy, then bladder dysfunction in diabetes, in what way the management differs?
So regarding the bladder, whatever be the cause, the drugs act on two things. One is the bladder and second is the sphincter. So it doesn't matter what the cause is, even if it's a congenital cause like a neural tube defects, or if it is a cause like diabetes, or if it's a spinal cord injury, basically the drugs are the same. And how you use the drug depends upon what the patient is actually suffering from. Like if you have a bladder prostate, as you said BPH, benign prostatic hypertrophy of the bladder, you need to see whether you need to first address it surgically, depending upon the size, so that would be your urologist's decision. And the second is you need to use drugs which actually relaxes the sphincter. So there your alpha agonist comes. You don't use drugs there to increase the bladder capacity like you use a oxybutynin or a mirabegron, because the problem is not with the bladder but it is basically with the sphincter. So you need drugs which will relax the sphincter like an alpha agonist. And you need to look at whether the there's a surgical intervention required or not. Other than that, if the problem is with the bladder, like you have a hypercontracted bladder or an overactive bladder, you use drugs which will relax the bladder. Like you use oxybutynin, the anticholinergic, or you use the beta-3 agonist like mirabegron. If the problem is with the dextrose sphincter dysenergia, where the dextrose is contracting and the sphincter is not relaxing, you basically want something again to relax the sphincter. So again you use a alpha agonist.
In long-standing diabetes, after the prostate surgery, the bladder function doesn't recover fast, quite often.
So that's what, sir. Again, depends on what actually is the problem. And the most difficult thing to control or to treat medically is when you have a hypotonic bladder. Because the drugs which can cause contraction of the bladder is cholinergic drugs like bethanicol. But they cannot be used because they have other huge side effects. So that is a bladder which is very difficult to treat medically. There, if the bladder is not contracting properly, the patient can use other behavioral modifications like a Creed's manual where you put pressure on the abdomen, or you can use Valsalva to voiding. If they have a continuous rippling because the sphincter is lax, they might have to go for surgery where they have sling surgeries where the sphincter can be tightened.
Thank you.
Thanks.
How people who are practicing for a long time have seen diabetic patients with bladder dysfunction and incontinence dying in a different way. The geriatricians say that fall is the beginning of the end in the elderly. And we have seen situations where the alpha blockers are used. The person gets an urge to pass urine at 2 o'clock in the night. He gets up, gets hypotension, falls down, breaks the hip, and that's it. They are bedridden for life. We have seen that practically. So as you clearly told, use of drugs has both values. And of course, you were mentioning about autonomic dysfunction also. In a male, of course, it is a problem with erectile dysfunction. And there also drugs have to be chosen quite carefully. As we all know, beta blockers are beta blockers. So they get really upset with that. And I've seen patients, young patients, who cannot even complain about their erectile dysfunction because of stigma. I think it's better be very careful, all of us, when we choose any drug in situations like that.
Fully agree.
Thank you.
Yeah, I want to make a comment on renal protection. We're moving really ahead, and now GLP-1 is the fourth pillar. So now the trials are going on internationally to combine oral GLP-1. SAMA has already shown the results, and SGLT2. That's one. And on the other hand, finerenone with empagliflozin. So that again would be, I know the cost we will always say, but yes, some people afford, some people may not, but we have to provide the best. It depends on the patient's pocket whether the patient can accept the best or not. This is what. Other is even non-diabetic causes should be kept in mind, and the studies have been done. Almost 50% like we used to think it is less, the number is quite high now. That non-diabetic, causes of.
We do give for non-diabetic kidney disease also. The confidence trial has come recently with the Finerenone and empagliflozin.
The potassium is more than 5. Can we continue ARB or AC? That means serum potassium 5.2 or 5.3. Can we continue AC? ARB
Sir, these are all transient. So, I am very careful when I choose my patient, even starting ACE inhibitor and ARB, if I know my patient will come back to me. Otherwise, I will have to really instruct him that these are the things that can happen. Potassium can rise. Because I have seen even a patient with a creatinine 1.5 coming and collapsing in front of the hospital with hyperkalemia, complete heart block, just because of hyperkalemia. So it depends. You know our situation, our food and all that. The people when they're tired, they drink coconut water. So it's very important that we educate the patient. And now I guess more patients are educated. But for me, I feel more than these medications, our lifestyle is very important. I have seen patients with creatinine 4 milligram for years together, for 5-6 years without any problem going with that creatinine 4. But at the same time, a man with a creatinine of 2 can have creatinine 10 tomorrow if he doesn't take care of his control. So control of medicine and hypertension is very important. Lifestyle measures are most important. That is what I would say is most important.
SGLT2 inhibitors, they can,
Yes.
bring down hyperkalemia.
Yes, it can do everything. It can decrease diabetes.
Thank you very much, Dr. Beena and Dr. Radhika, for your excellent lectures and the audience for the active participation. Thank you.
Thank you to the chairperson and speaker for that insightful session.